title septal CRT study. Please.
Good morning, ladies and gentlemen. On behalf of the steering committee and the investigators, it's my pleasure to present you today and to discuss with you the septal CRT trial. The septal CRT trial is a clinical trial designed to compare the influence of the right ventricular lead location, the conventional apical location versus mid-septal location. This is my personal disclosure. So the aim of the septal trial was to test the non-inferiority hypothesis that a right ventricular mid-septal pacing was not inferior to right ventricular apical pacing in patients implanted with a CRT-D device. The primary endpoint of the septal CRT trial was the changes in the left ventricular and systolic volume between baseline and 6 months. The main secondary endpoints were the percentage of echo responders, defined by a reduction in the left ventricular and systolic volume by at least 15% at 6 months, the implantation success rate of the right ventricular lead, and finally the proportion of patients with at least one major adverse event. This was a prospective multicenter European single-blind randomized trial with a one-to-one randomization, either to the apical location, either to the mid-septal location. This study was designed to detect the non-inferiority in the primary endpoint with a 90% power at the 2.5% unilateral significance level. We perform a per-protocol population analysis by the use of the lower limit of the confidence interval of the difference in the reduction of left ventricular and systolic volume between the two groups with a cutoff value of minus milliliter. The sample size was calculated to 240 patients with an attrition rate of 33%. This study was conducted in 25 centers in France and Spain. This is a flowchart of our study. We included 263 patients. This is the intention to treat population. From this patient, 9 patients died. 33 were lost to follow-up or have a premature exit from the study. And the echo was not analyzable by the core lab in 49 patients. So at the end, we had 182 patients with all echo data available, and this patient represent the per-protocol analysis, and they were well balanced between the two groups. This is the baseline characteristic of the per-protocol population. Most of the patients were male and were in New York Heart Association class 3. The mean left ejection fraction was 30%, and most of the patients had a non-ischemic cardiomyopathy. Finally, the cure duration was consistent with previous other trial, 160 milliseconds. What are the results? In both groups, we observe a significant reduction in left ventricular and systolic volume between baseline and 6 months, with a mean reduction on 25 milliliter in septal group and 29 in apical group. The per-protocol analysis did show a mean difference in left ventricular and systolic reduction between the two groups of 4.5 milliliter, with a lower limit of the unilateral confidence interval at minus 16.54 milliliter, so inside the non-inferiority margin. The results of the per-protocol analysis were reinforced by the intent-to-treat analysis, who found the same result. For the main secondary endpoint, there was no significant difference in the percentage of echo responders. 50% of the patients in both groups were echo responders. There was no significant difference in the implant success rate for the septum and the apical location. This slide shows the one-year mortality, and you can appreciate that there is no significant difference between the two groups with two superimposed curves. And finally, the conclusion of the first multicenter randomized prospective trial comparing RV apical and RV septal pacing in CRT-D patients is that we can demonstrate the non-inferiority of RV septal pacing when compared to a conventional RV apical pacing in CRT patients. No difference in left ventricular and systolic volume reduction between baseline and 6 months. Same percentage of echo responders. No difference in implant success rate. Also, no statistical difference for the safety and the efficacy endpoint, the same rate of mortality, and the same rate of major adverse events. Thank you very much.
Thank you. Any comment or question? Yes, please.
Yeah, Bruce Jansen from Cardiology News. Could you speak briefly about your motivation in conducting the trial? What are the clinical implications?
The clinical implication is that, as mentioned previously by Dr. Blanc, that we know that when you implant a right ventricular lead at the apex, you can modify the geometry of the left ventricle, and sometimes you can worsen the patient. And so in the CRT community, I would say there was a huge debate about interest of moving the right ventricular lead from the apex to the septum. And so far, we didn't have any clinical trial showing that this location, the new location, the mid-septal location, was as effective as the apical location or better. So it was the rationale for conducting this study. Because if, from a US perspective, I would say, especially in patients receiving a defibrillation biventricular devices, usually in US, most of the patients are implanted with the apical, and in Europe, about 60% at this time are implanted with the septal location. So it was the reason why we didn't know which was the best, and with the result, we showed it was exactly the same. So I think we can say that you do what you want.
Another question? Okay, thank you.
Thank you.
Presentation.